Dr. Ronald Carey is a professor of medicine unit 4. He has over more than 10 years of teaching and clinical experience. He has published multiple articles in reputed journals like Neurology India, Clinical Toxicology, South Asian Journal of Cancer. His academic interest in acute care and internal medicine. We welcome you, sir, for chairing the session. The second chairperson is Dr. Viji Thomson. He is also the speaker for our first talk. He is a professor and head of the Department of Cardiology. He has over 20 years of experience in teaching, training cardiology residents, advanced training in interventional cardiology and cardiac MRI from RH and South Australia. He has numerous publications in various topics of cardiology. His talk for today is on renal denervation for refractory hypertension. Sir, I welcome you to the stage to give your talk.
Good afternoon. Okay, good afternoon again. So I've just modified my talk a bit. So it will be what cardiologists can do for stroke prevention. Two of the areas which we'll cover, and the third will be hopefully covered by Ajay when he speaks on left atrial appendage closure. This includes renal denervation as well. So I'll give you two clinical scenarios. One is a 60-year-old male with uncontrolled hypertension, prior CVA, had a pontine bleed. He's compliant to drugs. He's on 4 drugs, but still blood pressure is uncontrolled. And he presents with features suggestive of giddiness or possibly a posterior circulation TA. The second scenario is slightly different. The young male, 32-year-old with no conventional risk factors, no prothrombotic state. He had history of a very long car journey. Midway journey, he got out, had to take some luggage out from the boot, and then he had a neurological deficit. So these two scenarios in mind, I move forward. Briefly about what stroke incidence and prevalence is. The crude incidence is around 1.7 per thousand. The crude prevalence is around up to 7 per thousand. The fatality rate is 18 to 20%, and 80% of the strokes are mostly ischemic. And intracerebral hemorrhage is around 12 to 35%. Now, this is depending on the data which we have here. Very few centers, mostly, so many publications, what they highlight the gray area is where the publications are from. So you can see the sparsity of data from all these areas. So what we are actually seeing is only the tip of the iceberg. And going forward, it means to say from studies that more than 55 years of age, 1 in 5 females suffer a stroke and 1 in 6 men suffer a stroke. And what it does is, because of treatment, the disability adjusted life years, 40% of the 40 million people have stroke, the global are pushed beyond the poverty line. So that is the economic impact the stroke has on. So this is to sort of sensitize you to the burden of disease among various risk factors, which includes the smoking, impaired glucose tolerance, low birth weight, which has got a bearing on catch-up in adolescent, obesity, pollution, gestation, and cholesterol, high cholesterol and kidney dysfunction. You can see almost it's close to 3,000 disability-adjusted life years. So it's a significant burden. So this is more current data as the transition of from around, this is 2000, this 2020. Still, the maximum burden of in terms of risk profile is still hypertension, close to around 2,200 per 100,000. disability adjusted life years. Smoking is considerably on its way down. And obesity is sort of plateaued, high fasting glucose also. But what you see is hypertension is still up there. So in the global perspective, so as you can see, this is the overall hypertensive population or cohort, so to say, women and men. And you can see 41% is undiagnosed. And in men, it's around 51%. What is interesting is these are diagnosed and treated and controlled achieved, 23%. Now, women in the Indians' perspective is close to, that's around 17%. 80% are not controlled. And you take it close to 60% are undiagnosed, 45 to 50% are undiagnosed. So this is the only population which are controlled with treatment. So it's a very significant burden what we're sharing. So my highlight today, I mean, what I'll talk on the next few minutes is probably to the population which is treated and not achieved. So the rationale for renal denervation is essentially hypertension is commonly neurogenic, a complex interplay of many factors. And recently we've identified the sympathetic nervous system overactivity plays a significant role in perpetuating, maintaining the high blood pressure state. And around 30% of patients treated for hypertension does not achieve target levels. So this is an old theme revisited. Why I say this is because this fact was known and it was acted upon as way back in the early 1930s when hypertension was difficult to control. They embarked on splanectomy or a radical surgical sympathectomy and bilateral nephrectomy in case of end-stage renal disease. This was very morbid and the mortality rate was close to 10%. There's a patient had severe postural hypotension. So then slowly it went back and it was not pursued for a long time. So this cartoon shows the complex interplay of the afferents, the renals, and the neurohumoral modulation. So it's perpetuated by many baroreceptors as well as chemoreceptors, the nucleus tractus solitarius, and also the rostral ventrolateral medulla, where is the seat of the sympathetic activity. So based on these afferent inputs, the sympathetic efferent outflow increases, causing all various effects. So what we are interested is, why are we interested in, this is the generalized hypersympathetic activity, but we are interested in more of a renal perpetuation kind or a neuroaffective modulation of the renal thing. So you can see a frequency dose response curve. When the sympathetic activity is up, but to this level, you have increase in renin secretion. A bit more, a dose response, then basically the urine sodium excretion comes down. The tubule reabsorbs more sodium. And then finally, when the frequency increases further, then it results in a decreased renal blood flow. So there are three effector organs which perpetuate from the kidney. One is the juxtaglomerular cells, where the renin is secreted which by beta-1 agonist receptor stimulation. The tubules, where increase in sodium absorption occurs and decrease urinary sodium. And finally, the vascular component, the efferent glomerulus, where the renal blood flow decreases. So this was the biological plausibility of the strategy of what is called a renal sympathetic denervation. See, this was year 2009, and Esler published this on a patient based on what we'll see briefly. 59-year-old refractory hypertension on 7 drugs underwent renal denervation. So we can see the parameters you look at is one is regional kidney spillover of norepinephrine, and also the whole body spillover, which is a marker of the sympathetic activation, estimating the norepinephrine levels. So left and right kidney, this is the baseline levels, and this is 30 days after renal denervation. And this is the whole. So considerable drop in the regional norepinephrine suggests a decrease in the sympathetic activity. So to say the ECG tachycardia has come down, the blood pressure response is good, it's coming down. And so is the muscle sympathetic nerve activity, again, an indirect marker for sympathetic activity. So this ended on this study, a Simplicity Hypertension 1 trial, and this what I'm showing you is the 3-year report. So finally we had around 8 patients. So the response at 1 month, impressive reduction in systolic as well as to the diastolic BP, and fairly sustained. So 1 month, 6 months, 12 months, 2 years, and then 3 years. So then came this study, the Simplicity 3 trial published in New England Journal of Medicine. So it was a prospective single-blind randomized sham-controlled study where the primary endpoint was a change in office systolic blood pressure at 6 months in patients having 3 or more antihypertensives. You can see the baseline and then at 6 months. So what it essentially shows is there was no significant difference between the sham group and the active group where had the Denervation. Now, what happened to all the observation studies which said earlier it works well? So this led to this editorial. It was a death knell, or say the Denervation train is coming to a grinding halt. And the author's editorial was written by Sripal and Visserli. So why are we still talking about this? Certain things in medicine defies logic. So long-term follow-up of the same trial showed at 12 months, the change in the mean office pressures, and this is the ambulatory. Always you see the office BP comes down, and the ambulatory BP also to say lags behind to a certain extent. So this is at 1 year, then it's at 2 years and 3 years, almost similar reductions to what we observed in that case study. So same with the ambulatory BP recordings. So this set forth another chain of trials, which is sham-controlled trials of notably 2 devices used for this renal denervation. This is the radio frequency ablation, and this is a piezoelectric crystal with ultrasound. Again, showing, see, because I've put the cartoon of the office because that's the impressive reduction. So minus 6 millimeters, minus 5 millimeters. Mind you, these are people with difficult to control hypertension. So that was the finding. So it is not something which is applicable for everybody, but very resistant or refractory hypertension. So who will benefit from RDN? One is refractory hypertension. You have a very rigorous workup. You rule out, especially if it's a youngish person, you will rule out all renal artery stenosis, vasculitis, coarctation. In rarer cases, including we refer to endocrine porphyric episodes, diseases, all this excluded. Then if it is not controlled with 3 drugs, of which maximal tolerated doses of 3 drugs, or 1 is a diuretic, then you would think of. And also exhaust all other, now more and more obese patients, non-obese patients have obstructive sleep apnea. They also fall in this category. All those characters still hypertensive. Then you could consider this therapy. Now, this is renal digital subtraction angiogram. You can see the renal arteries here. They look normal. And this is the catheter which we use. It's called 4 electrodes to ablate. So these are very high-end instruments in the sense that they give us a certain window during which the ablation is done. If either the contact is not good, or if the impedance goes up very high beyond 2170, or they auto shut off, providing a reasonable comfort to the operator that you are not actually damaging. So this was our first case, which happened sometime in April 2024. So this patient, I think we have given the right kidney and then the left kidney. So we did multiple ablation in all the branches. You can branches between 3 mm, or sub branches between 3 to 8 mm dia, we can do this therapy. Less than 3, there are issues and it's not advocated as per the directions of the manufacturer. Now, why I'm showing is this. So still a certain reason why the previous times didn't work, because more and more studies went into evolution of this therapy. Now, this is a proximal segment of the renal artery, and this is a distal segment. And what is marked in yellow is the nerve density. This is the lumen of the artery, and as you go abdominally is the adventitia. So you can see, so about 2 mm, 4 mm, 5, 6, and 8, so on. And this red circle sort of encircles the region where the maximal concentration is, which is between 0 to 4 mm in the proximal. But if you look at here it's much more compacted, the nerves. So proximal is around not as much compacted as the distal. So earlier, when I was in training in 2010, initially we used to ablate only the proximal 3 centimeters of the renal arteries. Now we become aggressive because of this. We go more distally, close to the bifurcation. We don't enter the renal hilum. So this is what essentially the changes which came on since the therapy initially came. So first patient was not very remarkable, I would say, because his drug numbers really didn't come down. But if you see the baseline, so even on these drugs, his blood pressure has come down. The ambulatory sort of lags behind. So it really didn't reflect much. So also I would like to highlight, this was probably the initial case. We had 36 ablations, 22 in the right, and the left renal was 14. The second case happened more recently, which a patient on 8 drugs. This was his baseline blood pressure 160, 100, and this was ambulatory BP. Whole pre-discharge, his blood pressure came to around 140, 100 on 3 drugs. So unfortunately, after the slide, he called me and said he's had to go up on 1 more minute. So I'll probably make it 4 now. So BP is okay, but still controlled. So he's on, we've added Prazopress to this regime. So it's probably 4 drugs, but a significant benefit. Now this shows that, see, we understood everything about renal denervation to actually know. So what we've seen is younger patients, relatively younger patients, the maximum number of drugs, they do benefit. So any new therapy, as is shown called, we need to monitor for side effect profile. 12% you have deep pain, it's around 12%. Usually we give some fentanyl and midazolam during the procedure. The pain subsequently post-procedure also can last for around, say, 2 days. It's managed with paracetamol. And in the study so far, I think in the world over, probably we've done around 15 to 20,000 patients. And the incidence of renal artery stenosis is 0.2%. So if you look at the natural history of idiopathic hypertension, the same rate of renal artery stenosis is prescribed. So it's not really attributable to what the device does. And the procedural risk for any transfemoral procedure is around access site, bleeding, etc. It's around less than 1%. So this is not a mainstay for, you're not going to change therapeutic armamentarium for blood pressure. But when you have very difficult to control blood pressure after all your medications have been exhausted. So why I say this now, ACE inhibitors, ARBs, beta blockers, calcium blockers have been well studied in multiple studies, starting from Alhart studies. But the newer drugs when you need to add on medicines like moxonidine, clonidine, you really don't know the cardiovascular side effects in the long term, the benefit. So it's an open-ended question, but if it's a difficult cases of controlled hypertension with all other glycerin exclude is a therapy for the future. I'll go on to the second scenario where we have some experience in stroke in the young. This was the just to recap, it's a 32-year-old male, no conventional risk factors, no prothrombotic state, long car journey, stopped his car, going back again, probably did a Valsalva and a stroke. Any guesses as to what the reason of stroke is? Thambu, you are bad. Anybody from the audience? Okay, moving forward. So transcatheter closure of PFO after a presumed paradoxical embolism. So it's a hole in the heart, but this is in 2016 again. This was the practice guidelines from neurology. It essentially said that should not offer PFO because, unless, a lot of riders probably not even a 2B at that point in time. And if it is recurrent stroke, they said they might consider. So this was essentially a very negative comment in neurology journal. That was in 2016. Now, 2017, there was a whole paradigm shift. They said just like how we would say AF and carotid stenosis is responsible for a stroke, it seems reasonable that if no other causes are really found and there is a PFO, you should consider. So there's a big shift in what transpired between 2016 and 2017. The reasons for it was, I mean, just for people who are not very patent foramen ovale, is there at birth. It's essential to get the oxygenated blood in the fetal circulation from the right to the left. So it is obligatory at that point in time, but it closes off. And the functional closure happens when the pressures in the left side increases by around 24 to 48 hours after birth. And the mechanical closure by fibrosis happens at around 2 years. Having said that, 25% of you sitting here might still have a PFO. So this started way back in 2012. It was initial why we embarked on these randomized studies was because the observation studies showed that PFO closure was beneficial. So we had between 2012 2013, and this RESPECT study had a follow-up at around 2 years. It really said that it didn't sort of push PFO closure as a mode of therapy for the future. But then came 2017, the core reduced, the close, and the RESPECT, which the same trial, when it was followed up, it showed a significant benefit. Now, why was this different? Mainly because of two reasons. In the first instance, the earlier, they were comparing all strokes, irrespective of whether there's lacunes or cortical strokes. By imaging, they did the PFO closure, and some of them were compared to oral anticoagulation. The second was the PFO was not clearly PFO was present, but we sort of refined on that. We say that which is a subset of PFO which will benefit from therapy. So those two things resulted in patients where better characterized stroke with a cortical infarct were considered, and also patients who had the rigor of checking. We said not only the PFO being present, but also the quantum of shunt quantification, then additional features like how the flow is directed. If you have a long eustachian tube, eustachian valve from the IVC, which is directing the flow, then came the angle. So many things were refined to really catch on the subset which will benefit, and then it showed a benefit. So this was the TIA, and the major bleeding was certainly in favor of device closure because you could stop the antiplatelet or anticoagulant therapy with this once the therapy was done. But with certain devices, there's still a small higher incidence of atrial fibrillation. So that was a worry. So combining this forest plot, you can see that there was a significant benefit in terms for PFO closure in studies of recurrent stroke. So the absolute risk reduction of around 3.2% in the number needed to treat was 31, considering it was basically a young population. Now, this is our PFO assessment pro forma for an echo, which is slightly different from a routine echo report, which we see. Basically, it's a transesophageal echo. And then we look at the size, the tunnel length, where the overlap segment, when it's more than 4 millimeters, again, is a high risk feature. In the atrial septal aneurysm, if it is present, again, the risk of odds of developing a stroke goes up, and many such things. So we started documenting these. So now to the unaccustomed eye, this is a toe. This is the interatrial septum. The flow, when it's close towards the probe, it shows red, and it's away from the probe, it's a blue flow. So this is the thick septum secundum, and this is the septum primum. You can see it's a bidirectional flow here in that tunnel, what we're saying. So this is the right atrium. This is the left atrium, and this is the right atrium. So how we delineate this, while we do this, we also do a contrast bubble study. So this is the right atrium being filled with the contrast bubbles, and you can see a few bubbles sneaking across the septum going to the left atrium. So this is sort of intensified when you do a Valsalva. Actually, we've seen that once people, when they do a Valsalva and a release, the same mechanism of a PFO occurred when I said, young person getting out, lifting a weight, and then having this. So the next slide is what I call the slide for the unbelievers. You see, that's a small hole, what can happen? But this is actually a thrombus in transit. It's making its way from the RA to the LA to go anywhere. It's your call. So this is the left atrium, and which really sneaking through. So that is what we're trying to prevent. There are many devices in the market. We're more familiar with the Amplatzer device, which is like most of the standard devices. It's got two ways, what we call, and the small disc, slight flexibility between this, and the left atrial disc is slightly smaller. So this is one of the implants. So this was an eyes guided one of the early ones, but you can see the device and that's how it seats. And the post echo, if you are familiar with that small red flow, blue flow, which is abolished by the device in place. So are there parameters to say clinically that who will benefit or which patients are likely to benefit? There's somebody by name Ken who devised a scoring. If you score all the no histories and negative, basically there's no hypertension, no diabetes, no TIA in the past, non-smoker, and the cortical gets 1, you get a score of 1. It's heavily weighted based on the age. If at the age of less than 30 takes points of 5. So this is the ROPE score. The higher the ROPE score, the population attributable risk of a PFO increases incrementally. So a young patient less than 30 with no hypertension can get a maximum ROPE score of 10, where probably if you see the PFO attributable risk of stroke is proportionally quite high. So it essentially, see, we call so even though if you do say 100 patients, 25 will have a PFO, does the cardiologist go close everything? Actually, no, because the neurologists are the gatekeepers. The referrals come from neurology to cardiology, and by documenting, they do a transcranial Doppler to see even if there is a PFO, if there's a right to left shunt. So intense neuroimaging, Holter monitoring, extended Holter monitoring, make sure there is no AF. This becomes more of an issue because in West, the atherosclerotic profile is slightly different a decade earlier, but in Indian starts earlier. So there will be a considerable group when you say a patient already has atherosclerotic burden in an Indian or phenotype, whereas West is slightly different. So there's been a debate, but then again, a very intense root search for the cause of the stroke. And then if you don't find, there's the new terminology where the embolic stroke of undetermined source is called the ESIS. So closing the patient for PFO closure, clinically, when you see if it's a high ROPE score, embolic stroke of undetermined source, positive transcranial Doppler study, this is there. It's a simple test. Actually, you can hear the hits. It's like a auditory sound. You hear the hit on the something like in the transcranial Doppler. And patent foramen ovale with high-risk features and moderate to large shunt on T. And always like the heart team concept where for TAVR now we have a cardio-neurology consultation to consider closure. This is our series of, this was way back in 20, we've added probably another 30 cases to date. This was published. So what I want to say is a very safe procedure. One patient had an embolism, which shouldn't happen even in a single case, but it happened. But the patient made an uneventful recovery. We had one patient with a residual shunt, which was a multiple fenestrations were there. So the beauty of that is if there's clearly ASS, you can see at 6 months to 1 year, a certain proportion of, this is the showing the regional distribution of PFO closures. As many therapies, the South calls the shots in terms of new therapy or adopting new therapy compared to the regions lagging behind. And this is the multiple centers. Again, the white centers probably the last 2 years got the maximum implants. One is our center, then Narani Hridayalaya, etc. So this is two publications for us. One is the initial feasibility challenges, and then the transcranial Doppler, and also a consensus document based on number of caseload. So what happens, like these young patients, once you have this, certain patients who can be gone off, certain patients, a single antiplatelet therapy, so around close to 60% can go off blood thinning medications. So it also depends on the time frame. We continue dual antiplatelet therapy for a month and then a single antiplatelet for around 6 months. So that is what this therapy does, a rewarding therapy, because especially the young patients are affected and you have a way of helping them out. So these are the two cases, scenarios I leave you with. When you think of either a difficult to control hypertension, you can you can refer to us, or in a stroke in youngs, refer to a center where they practice PFO closure. Thank you for your patient listening.